Next talk by Ismail.
Thank you, Professor. Let me share my screen. And I will be talking about the spine scales and outcome scores. So when we evaluate a patient and when we think about performing any kind of spine surgery, what we intend to do is reduce the pain of the patient, reduce their disability, improve their quality of life, and have them return to work or daily activities as soon as possible. So in a sense, when we perform spinal surgery, we are performing a comfort surgery. We're trying to increase the comfort of the patient and have a better quality of life. But
sorry, Ismail, can you make it all screen? We see all your, yeah, now this is fine.
No, it is good.
Thank you.
So when we're at the stage of decision making, as Emmanuel put it out, we first focus on clinical findings, and then we rely on radiology, maybe sometimes much more than we should. And then we try to evaluate the pain of the patient. We ask them if their pain is severe or if it's moderate or if it's light. And we check to see if the patient's symptoms or complaints are progressing. But what we tend to do is we forget about the patient's perspective, which is one of the most important criteria for a successful management of spine disorder, because we are performing these surgeries not to improve their MRI images or their X-ray images, where we are performing these surgeries to improve the patient's comfort. So in a surgeon's perspective, we can classify our approaches, our treatments, if it's an excellent approach, if it's a good approach, if it's a bad approach. But these are very subjective, and these tend to change per every surgeon, per every patient. And then we check the radiology of the patient, and we see if it's a successful decompression, if it's a successful fusion, and we tend to evaluate it as a successful operation. But what is more important is if the patient is satisfied. We may have a perfect post-operative radiology, we may have a perfect fusion, but the patient may not be satisfied with their treatment. And while evaluating this patient satisfaction, we need to objectively see their quality of life increase, their pain decrease, and their disability starting to disappear. And to do that, we need PROs. In other words, patient-reported outcomes, to actually see if they have a relief of their symptoms. So what are PROs? Patient-reported outcomes are direct reports from patients, and we need to ask them about their health condition, their psychological status, their symptoms, their pain. And it is important while we're following up on patients or while we are sharing our results to see if we actually performed a successful surgery. So the burden of the disease, the monitorization of treatment outcomes, to actually have a great patient and physician communication, to generalize treatment results, to see if it's a cost-effective approach that we performed. And we can use PROs to benchmark and quality improvement. So why do surgeons stray away from PROs? Sometimes it may be seen as it's an extra workload, because all surgeons have a lot of workload to see patients, to evaluate them, to perform surgeries, to do follow-ups, to train residents, and sometimes asking patients, giving them some time to make complaints may be seen like it's an extra workload. Sometimes these PROs are open to subjectivity, because these analyses are completely performed by patients, not by physicians. And patients may sometimes stray away from what is actually being questioned. Some patient-reported outcome measurements do not have validation studies, and these need to be validated before being performed in a successful manner. Not all changes in PROS actually mean a clinical change. So in each PROS, we have what we call an MCID, minimum clinical important difference, which is something I will get into detail with each scale. And also, statistical significance does not always mean a clinical improvement. So these PROS should be very reliable. It should be consistent with each patient and each pathology. It should be valid. It should be able to measure in actuality if the patient has improved symptoms or not. It should be very responsive. It should be sensitive to what we are trying to measure. There are numerous PROS out there, but when we're performing spine surgeries, it should be very sensitive to spine surgeries, and it should be acceptable. It should be appropriate for that patient. So to categorize the type of different patient-reported outcome measurements we use, we can mainly categorize them into four to measure their pain, their disability, their quality of life, and the psychological aspects. So one of the most common and probably the most known PRO out there is the visual analog scale, which was first discussed in 1921, about 100 years ago. This is very useful, very easy to implement, very easy to follow up, and almost all patients are comfortable answering any kind of visual analog scale or numeric scale. So in the visual analog scale, we have a smile face and a very severe pain at the 10th degree. And we ask the patient to evaluate their pain. In the numeric scale, we give them a scale from 0 to 100 or 0 to 10 and ask them to categorize their pain. But we should be specific about where their pain is. We can have a VAS for lower back. We can have a VAS for arm, for neck. So when we're doing any kind of assessment, we should put down the localization of the VAS, but it's very subjective because it will change from person to person, because when a patient is analyzing their pain, they're actually referring to their memories of previous pains. So let's say, for instance, if we ask a woman about her radicular pain, she may use her birth pain, while if she gave birth previously, to compare that pain previously. But if we ask a man, he may not have such a major history of pain to evaluate it. So it may be very subjective. So while evaluating disability, one of the most commonly used is the ODI, which is the Oswestry Disability Index. It's one of the most commonly used PROs out there because it's very comprehensive, and it is very validated for the functional disability caused by spine pathologies. So there are 10 different questions which focuses on pain, everyday activities such as dressing and bathing, lifting weights, walking, sitting, standing, sleeping, their sexual activity, socializing, and their ability to travel. These questions are not questions that we routinely ask our patients. We usually ask them if they have radicular pain, if they have numbness, where their pain is, if they had a history of surgery previously. But these questions are important to ask before the operation and then follow up on the patients to if we have successfully performed a treatment. If the increase in ODI is not more than 10%, that means we were unable to decrease the disability of the patient. And in a sense, we were unsuccessful in treating that patient. The MCID, the minimum clinical important difference, is around 10%. So we need at least a 10% increase to say that we were successful in decreasing the patient's disability. Another questionnaire, which is a comprehensive questionnaire, and it involves 24 different statements. And sometimes this questionnaire is more appropriate for prospective studies, is the Roland Morris Disability Questionnaire. These are very simple sentences, and most patients are very comfortable in filling this out, but it just takes time. So each statement has 0, no impairment, to a total of 24 severe impairment. every question has a 0 and 1 point difference. And the MCID is around 3 to 6 points, which is a clinical improvement that is actually significant. Another frequently used pro for disability evaluation is the Quebec back pain disability scale. And this is validated for lower back pain. This can also be used for different kind of prospective studies. It's a condition-specific questionnaire. So it allows us to evaluate if the patient is able to use their back or their lower back to perform everyday activities, such as climbing one flight of stairs, throwing a ball, or making their bed. These are very simple, everyday routine activities. And these are very important because if a patient is able to perform most of these activities, then we can speak about their disability almost disappearing. So 20 different simple activities, and each has a score from 0 to 5, which is no difficulty at 0 and 5 maximum difficulty. And the final score is evaluated from 100, and the MCID is 20 points. Another disability which focuses on patient-reported outcome is the neck disability index, which is also very famous, and it solely focuses on neck pain. But it is very comprehensive because it has a section on pain intensity, on personal care, lifting, working, headaches, which are very common in neck disabilities, concentrating, sleeping, driving, reading, and doing recreational activities. And this questionnaire has 10 different questions with 6 possible answers, and the final score is between 0 and 50, and the MCID is 8 points. And this also gives us 5 different categories from no disability to complete disability. Another disability score focusing on the neck is the Neck Pain and Disability Scale, NPDS. And this is a bit more comprehensive than the Neck Disability Index, and it also focuses on emotional effects or changes in mood resulting from pain. This is not really focused on NDI, but in the NPDS, the emotional effect of the pain is also evaluated. It's a bit more comprehensive. It has 20 different questions, but it has a visual analog scale, just like the one we use in pain analysis. And from 0 to 5, we have the patient fill them out. And the maximum score we have in this is 100. So the MCID is around 10 to 15 different points. The numeric grade manual also touched upon it is useful in patients with cervical myelopathy, because myelopathy is not just a disease of pain, but it's much more comprehensive in creating symptoms in the lower extremities as well. So when we're dealing with the treatment of cervical myelopathy, we should get the numeric grade of the patient before the operation and after the operation to see if we actually made a difference. So in grade 0, it's a normal, completely normal patient, while a grade 5 is a bedridden patient, a patient who can't ambulate, who can't perform everyday activities, and who constantly needs someone to help them in their daily activities. Another frequently used pro for cervical myelopathy is the MGOA score, which is the Modified Japanese Orthopedic Association score. And this evaluates both the upper extremities and the lower extremities to see if the patient is able to button their shirts, to see if they're able to eat on their own, if they're able to walk on their own, if they have severe sensory deficits. And additionally, it also has the sensation score, which is very important in myelopathy patients. And also, additionally, from the numeric grade is the sphincter dysfunction. If the patient has urinary incontinence, or if they're unable to urinate, and if they need a constant assistance in urination. And after that, we have a total score of 17, while 18, while a mild myelopathy is between 15 and 17 points. A severe myelopathy is between 0 to 11 points. This is fairly simple, and most surgeons do actually, especially in Turkey, perform the MGOA score because it's a scale that you can fill out on your own without asking the patients many questions, because you just simply ask them if they're able to get dressed on their own, if they're able to walk on their own, if they have trouble with their sphincters, and if they have a sensory loss. So this is fairly simple to use, and it has been validated for cervical myopathy patients. The quality of life assessments is a bit more time demanding, and sometimes surgeons may need assistants or residents to help them out, because this is much more comprehensive. It focuses on very specific, detailed things that the patient can perform. And it is comprehensive, and it is accepted as a benchmark scale for many of the publications you may see on quality of life. So it is validated for spine, and it has physical and mental and 8 different domains. And there's a total of 100 points that the patient may have. And the 50 points are given to the average measurements of a routine person. So what we can do is we have a mean score around 50, and we can have that benchmark. So if the patient is lower than 50, we can say the patient has a very diminished quality of life. And if we are successfully able to increase the patient's score over 50, then we can say we actually performed a successful operation. So what is different from other questionnaires is this questionnaire does not focus solely on pain or body pain or physical functioning, but it also asks the patient if they're able to socialize, if they're able to go out and meet with their friends and do what they like, if they have emotional distress, if they have depression-like symptoms, if their mental health is dysfunctioning. And the MCID is 5 points, which is fairly low considering there's a total of 100 points. So it is very sensitive in assessing a patient's quality of life. The World Health Organization also has a quality of life assessment. It is not frequently used for spine patients because it is very, very comprehensive. It is actually used for evaluating, the quality of life in countries' measurements, in big, large population studies. But there is also a decreased version of the WHO's quality of life assessment, which is the BREF. And you can use this to focus on 26 different items, such as physical health, psychological health, social relationships, and environmental relationships. But as I said earlier, it isn't very specific for spine patients. But the EQ5D, your quality of life, can be used frequently for spine patients because it's very easy to implement. It doesn't take a lot of time. It is fairly simple, and it focuses on 5 different categories, which is the mobility of the patient, the self-care of the patient, their daily usually activities, their pain and discomfort, and their anxiety and depression. So you can see that most of the quality of life studies focus on pain, mobility, if the patient is able to walk around and do their things, their daily activities, and their emotional status. And lastly, the psychological aspects. Patient-reported outcomes are, as I said earlier, fairly missed by surgeons because it takes time. It takes a lot of time, and you need to ask the patients a lot of questions. And psychological aspects is the area that is least touched upon, but it's actually one of the most important subjects when evaluating a patient because the prevalence of mood disorders amongst spinal disorders is very common. And there is a numerous number of studies focusing on whether the patient had preoperative depression or anxiety and their postoperative satisfaction. So to simply state it, if the patient has a very deep depression or a very high level of anxiety, it is very difficult to have a satisfied patient in that sense. If they have a high level of anxiety, no matter how excellent your radiological evaluation is, or no matter how excellent your surgery went, the patient may come out unsatisfied. And since we perform these surgeries to satisfy patients, in a sense, to increase their quality of life, we should really focus on psychological aspects as well. And one of the most frequently used one is the BDI, the Beck Depression Inventory. It's a bit comprehensive. There are 21 different questions, and each question has a scale from 0 to 3. Focuses on sadness, pessimism, sense of failure. If the patient feels like they won't ever get better again, they won't ever be able to have an active status in society, their self-dislike, suicidal thoughts, weight loss, work inhibition, sleep disturbance, their fatigue level, and their loss of libido. And the Zong Self-Rating Depression Scale, the STS, this is also very comprehensive, and a lot of studies actually use this to evaluate 20 different statements. And there's a scale, a Likert-like scale that you use, and each statement has a score between 1 to 4, and it's very specific for detecting and very sensitive for detecting depression. Another frequently used pro for evaluating psychological aspects is the HADS, the HADS, Hospital Anxiety and Depression Scale. And this has a lot of validity studies, and it has been shown to be very sensitive in detecting anxiety and depression. There are 14 different multiple choice questions and 2 different subscales, with having 7 questions in each subscale and a total score from 0 to 21. The FABQ, the Fear Avoidance Beliefs Questionnaire, it has 16 different questions, and the higher the score, the greater the fear avoidance beliefs related to work and physical activity. What is important about this scale is and the reason why I put it is, sometimes the patients have so much pain before surgery, and the surgery itself is also a very painful process, both physically and mentally. And afterwards, the patients are very afraid to do daily activities because they're afraid that they may have a recurrence. They're afraid that they may mess with the fusion or with the instrumentation, that they just pull themselves away from daily activities. They start to do less. They start to move around less. And with time, you can see these patients have a very atrophic musculature structure, and sometimes they may even gain weight. And these also make the underlying disease progress even faster. So it is very important to see that we can actually say to the patient that you are able to freely move around and do what you like, as long as it's in the suggestions of the surgeon. So I gave a lot of different patient-reported outcome measurements, and a simple question that you may ask is, this is very difficult. How many pros can we ask the patient to fill out? How many pros can we fill out about the patient? These things take a lot of time, and each scale is at least about 5 to 10 minutes. So taking into daily activities, we tend to see the patient around 10 to 15 minutes. And to have a patient fill out or wait for the surgeon to ask the questions takes a lot of time. But it is very important. And I believe, which I didn't put in this presentation, is there are more and more artificial intelligence studies focusing on if the patient will benefit from the surgery or not, if they will have an increase in their quality of life or not, if they will have a pain decrease after the surgery or not. And this will be very important later on because we will have software, and we will have the patient just use that software to fill out simple questions. And then we will analyze the patient to see if what we're planning to do will actually satisfy the patient or not. I believe the future lies, especially in the sense of patient-reported outcome measurement, is in AI, because it will be very impractical to perform each kind of pro on each patient. But we should definitely know that neurological examination and radiological examination is not complete without patient-reported outcome analysis. We should also not rely on every single different points after the surgery, because the MCIDs tell us if this is clinically significant or not, or if it's just a statistical difference or not. So in each slide of our colleagues, we can have this sentence. We can tailor outcome measures to specific patient needs and clinical questions, because each patient has a different expectation. We may have an 80-year-old patient who just is asking for the relief of their sacroiliac joint pain. And as Professor Zileli put it out, we can have an injection and make that patient very happy. But we may have a 30-year-old patient who's very active and who needs a very stable spine, and that patient may need a fusion surgery. So there are a lot of different patient-tailored aspects, such as pain, functioning, the neurological and the psychological status of the patient, and the quality of life. And we need these pros to actually promote standardization to see if patients actually are better with surgery or not. So our primary goal is to reduce pain and disability, but it is also to improve quality of life and occupational capacity, so the patient is able to return to their daily activities as they did before the surgery. Thank you.
Thank you, Ismail, for your excellent talk. And I think we are running short of time because another session is going to start in next 20 minutes.